Okay, there we go. How's that?
We've got it all. Thank you.
Great. Yeah, if you run a medicine company, can't properly perform the tasks of a video conference, that's bad. So, glad to be here. My name is Matt Kaufman. I'm an ER doctor. I'm going to talk a little about our work with our group called StationMD, which is a telemedicine company that's really focused on serving people with IDD, and I'll show some of our work. So really, as should be with every medical endeavor here, our primary interest and mission is to improve care and provide quality care. And that's something that we're extremely proud of. We have ER doctors that are specially trained to take care of people with IDD. We have very robust quality measurements and quality reviews. We are very proud of this work. Really, I've been an ER doctor for a long time. This is by far the most, I feel like the most meaningful work I've ever done. While we are servicing this population, we are also reducing ER and hospital use, and we're cutting costs, and we'll talk about that, because without cutting costs, or at least having it pay for itself, it doesn't happen. Let's see okay, there we go. So I mentioned some of this stuff here. I'll just keep going. So we're all ER docs. The group was founded by 4 ER doctors. We right now are in about 120 group homes, 13 skilled nursing facilities. In 2017, we had about 2,200 calls. We're expecting far more, over 6,800. 6,800 in 2018. That's a done deal. In 2019, we just heard about a Medicaid grant in New York State, which is going to expand our population that we're going to be taking care of to over 6,000 patients additional to these. So we're extremely proud of what we're doing. We're growing, and I'll show you some of the data. As I mentioned, we are specialized in the population with IDD and other disabilities. We are in these various groups and states, New York, New Jersey, soon to be New Jersey, and Ohio. We have a pilot as well. So let's just talk a quick overview about why this is so important. This work is so important for people with IDD. I call them patients. I'm a doctor, so when I think of people, I think of my relationship as patients, but I know that that's not the case for everybody on this call. But forgive me for using that terminology. So what happens when a person with IDD shows up, and what are the dangers of going to the emergency department? Well, it's first of all terrifying. It's terrifying for many people, not just people with IDD. It's terrifying for almost anyone. The ERs that I work in and have worked in, are particularly loud. There's oftentimes people under the influence of drugs or violent. There's plenty of stuff that could upset anyone. If you add on someone with sensory issues or other issues, you're talking about it could be a real trauma for someone emotionally. Then the trauma transport itself, moving people with IDD around who have different conditions can cause additional injuries. They're exposed to infections. And then I think one of the other things that's maybe not talked about as much is really just a general disruption. You're missing meals, you're missing activities. When you have someone who's very accustomed to a pattern of activities and you disrupt that, it reverberates. I mean, I think that everybody on this call probably knows that very well. And so, they can miss medications. I've seen people miss their seizure medication while in the ER. They miss a medication and then have another complication, which just seems crazy. So why does this population get transferred so quickly and so frequently? Well, there's a bunch of reasons to it. First of all, this is a population with a lot of comorbidities and high risks. So there are legitimate concerns about health. There are frequently comorbidities such as restrictive lung disease, asthma, intestinal issues, and so forth. And then, of course, there's just defensive medicine. People are taking care, the docs and providers that are taking care of people with IDD are worried about getting in trouble, getting audited, getting sued. The pressure is to transfer. Sometimes the family is concerned about something and they want something urgently evaluated. So they're pressuring the staff at a facility or a doctor to organize an immediate evaluation. And there's regulatory requirements. I mean, we all get audits. We all get the state looking at our charts and so forth. And there's pressures there. And then, of course, the primary care doc, if he or she is not available, they may say, I want this patient evaluated right away. So we basically, what we do is we bring the ability to evaluate a patient immediately to the bedside where the patient is. And you'll see a doctor like me. And with the help of a staff member, or sometimes the person, him or herself on his own or her own, we can do the evaluation. And I'll talk a little bit about what that looks like. And we evaluate the patient and are able to make medical decisions. We have a stethoscope that actually we're able to listen to heart and lung sounds. It's transmitted through the computer, and we can listen to, it augments our exam. We have a visual, obviously, with a high definition camera that allows us to really evaluate the patient visually. And it really makes, it's able to give us a picture, I would say, of the vast majority of patients. What we're missing out by not being there is very small amount. So the process is the caregiver, the patient himself or herself, the staff member, the nurse notices a change in condition. They activate the StationMD process, which is basically one button. The physician the physician implements a treatment plan or recommends a treatment plan. The patient is treated. We perform quality assessments, and that's the overview. So a typical case, 24-year-old female with cerebral palsy, asthma, develops a cough and spikes a temp of 101. This is a classic case that we see all the time, especially this season. Saturation drops to 90%. This would be a patient who is in an ICF or a DCF. So we have access to vital signs already. People who are in more independent settings typically have a very inexpensive but effective vitals sign machine that allows us to get vital signs there too. The nurse or direct care staff contacts a StationMD in this case. It's a real case. The doctor reviews the patient's records. I do want to emphasize we're not a one and done kind of show. We have access. We basically become part of the staff there. We become part of the care team with our partners and clients. So we have access to the medical records. We can review that. We can see if the patient was recently discharged from a hospital, recently on another medication, what other medical issues that are relevant, and that we take that into account. And I would argue that taking the time to do this is far superior than what we normally see in an ER. When I'm in an ER and I see a patient, especially, what happens with a patient with IDD, they usually come in with a book that's like, this thick, 3 or 4 inches thick. I'm trying to sift through and find out the relevant stuff. I'm like, just let's test for everything. Believe me, I'm going to find a reason to admit that person, and they end up getting admitted. I'm not proud of this. This is part of the problem. When I'm seeing someone via telemedicine and someone on my team that sees someone on telemedicine, we're taking our time. We're focused on that person. We're having access to the medical records, and we're actually able to talk to the staff member that knows that person the best. So it really is a superior ability to deliver care. In this case, we're concerned about asthma and infection. We we prescribe nebulizers, steroids, antibiotics. And this is depending on the setting. So we can do this in a number of ways. We sometimes just send a prescription to the local pharmacy that this person uses. Other times, the patient already has nebulizers, and we can just increase the frequency. So there's varying scenarios that we can prescribe treatment plans, but we tailor to what the availability is there. In this case, the outcome was, again, we're not a one and done kind of shop. Our doc reevaluated that person in a couple of hours, saw that the oxygen saturation improved, saw that the temp came down, the exam improved. We wrote our note in the electronic medical record that is part of the system that's in place for that person. And we avoided a trip to the ER. And I would argue in a case like this, you almost certainly avoided a hospital admission, which is a huge cost, not just for the patient in terms of his health and trauma, but also in terms of dollars. We have our initial pilot was a Medicaid-funded pilot, which showed an 89% decrease in ER transfers in 2 pilot sites. That number has actually persisted, it wasn't just a fluke of 2 sites over a couple months. This has gone on for over a year. This graph shows the months over about, I think, 14 months. And what the total bar, the top of the bar shows is the total numbers of calls. The blue represents those calls that we were able to treat in place. The orange represents those calls that actually we had to end up transferring to the ER. So you'll see there's a lot more blue than orange. A lot more patients were treated in place. This gives you a sense of what those diagnoses were. I'm just going to do a quick check on my time here. I'm doing okay. Basically, we see the vast majority are infectious. So pneumonias and upper respiratory tract infections were most of them. You see cellulitis over here. And then other frequent calls were a gastric tube malfunction, which will, as you guys, many of you know, will end up in an ER as well. But if we can fix that in-house, then we're able to do 100% of these cases were fixed in-house. Diabetes management and so forth. I will point over here when it gets too serious, like full-on sepsis. Obviously, we transferred 100% of these to the ER. And this is just some cost savings data for our pilot. And again, this data is from a total of 30 patients, a very small number of patients. But I want to show you the impact that it had on the cost and the value that was really saved here. So this on the left side here, the green, is what the facility itself saved using this telemedicine process. Now this will vary depending on the state and what the facility is responsible for paying for. So keep that in mind, but I'll kind of walk you through it really quickly. So we total number of calls of 144, 128 treated in place. So that means that 16 ended up sending to the ER. 16 we basically made no impact. Said send them to the ER. We can manage them via telemedicine. Fine. So we're left with 128. Now of that 128, we said that we actually saved. If we say that there's an average night, we basically estimated what percentage of those were going to be admitted. Based on those admissions, we said if they were more or less 5 admissions, the cost of the bed that was lost, that ended up being 129 nights lost revenue, and it ended up costing the facility $54,000. The transportation, in this case, the actual facility was responsible for transportation. That cost approximately $500 per transport, another $64,000. And then there's overtime. And I know that staff shortages is a big issue for many sites across the country. And you're having to pay time and a half to salary, and not to mention disrupting the entire workflow of the staff in the facility. So just based on that, they saved $35,000. If you add it up, that 30 patient, from those 30 patients over, I think, 3 months, they saved $164,000. The pay really very well, because if you talk about an average ED visit, you're talking about $1,000 per ED visit, which ended up being $128,000. And we estimated that 43 of these 128 would have admitted based on their diagnoses and based on the percentage that typically is admitted when they go to the ER. And at an average rate of $15,000 per admission, That was another $645,000. So you're talking about a payer saving $773,000 on 30 patients. I'm going to pause there to see if there's any question. I'm going pretty fast through this.
Yeah, I'm not seeing any questions pop into the chat yet. So if you guys do have questions, go ahead and throw them in there. What types of in homes and environments are you guys doing this in, or can you describe those 30 homes maybe? Just kind of
those aren't 30 homes. Those are 30 patients. There were two DCFs. That's all. 30 patients in pretty closely monitored facilities. These were typically high utilizers in the system, so they were fairly fairly closely watched, and the staff was pretty robust in these facilities. Because of this data, we were asked to roll out to 106 sites within this population, within this specific group. And as I mentioned earlier, we are very excited because we just got word that we are rolling out to many more individuals throughout the state of New York based on this data and the success. So, but we have a model that is not just for people in group homes or ICFs or DCFs. We have a model that is also for people who are more in a community-based setting in their own apartments and so forth, maybe with a staff person checking in or virtual staff, as I know Rest Assured and some other models have. So we have models that fit sort of basically every different scenario in the community.
Yeah, very cool. So there was just a question that came in that says, does this treatment depend on having nursing services present? If there's not a nurse available, would this work?
It's a great question. The short answer is no. We implement this treatment with whatever, again, our sort of philosophy is to use whatever this sort of organic situation is to that person. So some of these people do have nurses in their facilities. Some of them just have direct care staff who have no medical training, essentially. And we partner with whoever is there who knows the patient. It could be a parent, could be a loved one, could be a nurse, but it could be just a staff member. And even in some cases, it could be just that person himself or herself. So the answer is absolutely not. There is some training that goes into this, but really the doctor and provider are there to sort of walk the person on the other end through the whole thing. And it really is quite simple. I mean, being our arms and helping us sort of apply this technology is very, very simple. And it's just an instruction. I do it like I'm doing now. So I say, put that scope here, this person, them stop, let me take a look at that leg, put the camera over here. It's really quite simple stuff. Did that answer that question?
It did. I think you did. She actually had a follow-up. So what if, a lot of the individuals that you may be serving may just want to socialize or for attention seeking call the care center frequently. Did you guys get that, and how do you deal with it?
So most of our contracts now do have a conduit. So we have someone who is actually facilitating the call. So a lot of those are filtered out. But look, the scenario that you paint is something that we deal with every day in the ER. I mean, we have people who come to the ER to see us or come to a doctor's office to have something. And usually, oftentimes it's presented as a somatic complaint. And we realize that there's some social element to it. We know how to do that. Well, that's what we do. I mean, it doesn't matter. Then we address the somatic complaint, make sure there's make sure that there's any physical issue that's covered. And, we move on. I mean, that's part of being a doctor. Sometimes it's hard to tease out the physical from the emotional. I mean, that's regular day for us. Anybody else?
Okay. I think that's all I'm seeing right now.
Okay, so I'll just zip through these last couple slides here. This just shows. I just want to show that with our new clients that are not part of that group, really this data held still we see an 86% reduction, really consistent down the line. And again, I just want to mention that we really have a comprehensive solution. We are developing protocols specific to this population. We perform educational activities for the staff, because I think really it starts there. It starts really with direct care staff and educating these folks on some of the important things to look for. And one of the really wonderful things that I had not anticipated for this project is how much the staff really loves it. When they get engaged, it really adds another element and dimension to the work that is empowering and very cool for them, I think, most of the time. And look, we all know how dedicated staff is working in this field. I mean, it's really a special field full of people who really are out there helping people. And, I didn't really understand that to the degree that I do now when I started this work. And engaging them to sort of add this additional dimension of medical care is a wonderful thing.
Yeah. Hey, I mean, that's one of the things that I loved about this the most when I first saw it and first talked to you, is thinking back to my days as a DSP working in the home, just the sense of comfort. Knowing that there's somebody that back there that can, I had my back, I guess. And then also as a supervisor on call for a provider agency, knowing that I could rely on a trained professional to help make those evaluations and make my job easier would have been awesome.
Yeah. No, I mean, we thanks for saying that. I mean, we are really happy about that sort of important byproduct of this work. To give you, so we actually do a whole reporting package for our partners, talk about when the calls come in, what types of calls, the data regarding diagnoses and transfers. And we sometimes make additional suggestions. We saw 2 people have the flu. We suggest everybody get put on prophylactic Tamiflu types of things like that. Again, as I mentioned, we've developed specific guidelines, standards of care for our docs. We don't like to see a lot of deviation in activity. I don't want you to call one doc and have a different experience. You call another doc at a different time. I want our guidelines to be very standard. This is very similar to how an emergency department is run, and that's what I'm used to doing. Again, we go through our quality very seriously, review cases that have outcomes that are unexpected. So if we have time, I can show just a quick little video to give you some sense of visualization. Some of it works a little differently depending on where you are, but let's see if this works here.
Anytime a nurse sees something of concern that warrants a physician evaluation, he or she simply wheels in the station, enters some basic information, and the visit starts in minutes. Our technology allows for a physical exam similar to how one is performed in person, including a detailed head and neck, neurologic, cardiovascular, and pulmonary exam. A telestethoscope transmits sounds directly to the physician's computer and allows him to listen to the patient's heart, lung, and bowel sounds. In any setting, when necessary, a family member can be conferenced in. In home care and residential settings, a similar process allows us to evaluate patients and prevent unnecessary ER and hospital visits. The visiting nurse or caregiver carries a portable tablet that has the same capabilities as the station in the nursing facility. As in the facility, we perform a physical exam, we address questions and concerns, we make a plan, and we give prescriptions and orders when necessary.
So basically, it just shows that there's a cart here that is just basically a computer. Sometimes it could be on a phone, sometimes it can be on a tablet. And this is an example where it's more of like a nurse-like scenario. And we're instructing essentially the conduit, doesn't have to be a nurse, where to put the stethoscope, what to do. We are there sort of monitoring the entire process and instructing. This shows that you can conference in family members. It's based off the Zoom system, so it's the same thing. This portion of the video just shows that it can be in a home care setting with a tablet. again, this is a model of like a visiting nurse type of thing, but it doesn't have to be. It can be a family member or anything. And again, we are visualizing the patient, going through the issues, and just coming up with a plan. That's really all I wanted to show from that angle. But
it's helpful to kind of visualize it.
We actually have a little bit more of an updated, sleeker system at this point. That was one of our earlier incarnations, but you get it. It's really very simple. There's nothing we specifically and purposefully have, made this an inexpensive technology. I mean, you can find robots that cost $35,000 out there, or $100,000. Our goal is to do this as inexpensively as possible and to expand access in that regard. That's it. Let me stop sharing.
Hey, Dustin.
Yeah.
Can I jump in a second and say something?
Yeah. Hey, Craig, how's it going?
Hey, great. This is guys. If you were on the call last week, I'm Craig Escuday, and I talked about the health risk screening tool, and I've had a couple of conversations with Matt, and I just want to say, and this is totally unsolicited, that as a physician who's practiced in this field for a number of years, this is an extremely valuable service, and I just think what you guys are doing are great, and it's very needed to have clinicians who understand some of the particular health issues that people with developmental disabilities deal with, and some of the things that are more common. Great service, and I can't wait to see it grow and bloom, because it's definitely something that's needed out there.
Well,
great job.
Coming from someone with Craig's experience and knowledge, that's a real honor, and thank you very much for the kind words. We're proud of it, and thanks very much.
Absolutely. Yeah. Thanks for what you're doing.
Thanks, Craig.
Sure.
So, Matt, you have two other questions. What states is this available in, and the cost, obviously.
The states one is easy. So the only requirement that we have in terms of states is that we have to have licenses there, medical licenses there. So right now we're in New York, New Jersey, Ohio, hopefully soon to be in other states like California, but we could do it anywhere. It's the only lead time issue is that medical licensing piece. So we just license up our docs to whatever state we have a contract in. As for the cost, that's a longer answer, which is it's the cost. It varies depending on the structure. So the high level cost we'd say is somewhere around $30 per member per month. Sometimes we do a combination of bringing that number down and then charging a little extra per call. The $30 per member per month is basically full coverage. You call as many times as you want, doesn't matter. In certain populations, it makes more sense to make that number a little bit lower and then tack on a cost per call. We just need to pay for our docs to be on call, and we titrate the cost to the how many docs we need on at any given time. Sometimes that cost is picked up by the facility itself. As I showed you, the facility itself, depending on the state and the structure, may save enough money that it makes sense for them to just pick up the costs. The payer would be the real winner here, and that's really who ultimately we're hoping, as the sort of systems evolve in various states, that's ultimately how we're hoping it works. Is they recognize they're saving so much money, improving care to the degree that they're willing to, create a new box to put this in, to say, hey, we're gonna do that. And a final scenario is the states sometimes, depending on the waivers for technology and so forth for people with IDD, it can be baked into that as a technology waiver to improve activities of daily living and so forth, to avoid these types of trips. So, we basically come up with a proposal, and I'll do this for anybody who's interested, a proposal for the cost based on some of the information that we get, where the patients are, and how many calls are anticipated and so forth. But that's the very quick, simple answer.
Okay, cool. We just had a question on how is it accessed and in Ohio, and I just kind of threw in the chat there that I really do feel like what you guys are doing will fit within the new AT rule there in Ohio, and other states that have similar, assistive technology rules. Depending upon how that language is worded, it may or may not, I think, fit in there. So you guys are talking to DODD in Ohio, right? What's the feedback there?
Yeah, we are, and they've been very encouraging, but they've also sort of said, hey, look at some of the counties. Let's see if we can implement it with, let's see how it looks with some of the local folks doing it first, and then we'll work it back in. And so far we have a pilot that is going on in Montgomery County, and we're looking to expand with some other folks. But again, I think the trick is to get these, get the stakeholders to come up with a model that works for everybody, and just sort of negotiating around those issues.
Yeah. All right. Good. You hit this right on the head. It is exactly 12:30. Nice job.
Thank you. Thank you, everybody. Thanks for the good questions.
Yeah. Hey, thanks, Matt. I appreciate it.